would like to thank for the audience for staying with us. We thought it's only 5 of us. Luckily that we have a few. Thank you very much for this. I hope I do justice to your present by make it short, and hopefully I can share a few information so that together we can learn a few simple things from our humble experience. So I was given a task to talk about 5 projects that has been established in our country. And actually these 5 projects are the reason why the Ministry of Health and Ministry of Home Affairs agreed for the program of methadone to be established. So my topic is from zero tolerance to full acceptance. From Prof. Hussein's talk just now, we know how difficult for us to establish the usefulness and the benefit of substitution therapy for abuse, drug abuse. So many hurdles and resistance that they face. I mean, Prof. Hussein is known as a methadone professor. It's not because he's on methadone, but he's the one who make the pathway for the methadone to be used and to be used as the main treatment. Of course, besides methadone, buprenorphine or suboxone also being used, but not as the free treatment. The buprenorphine is available as can be given in the clinic, but the person have to pay. But methadone, when we are talking about the methadone program, the methadone is given free by the government. So I would like to divide into 3 parts for this talk. One is what we learned from the past. The second part is the main one, to talk about the 5 projects, and last, hopefully, what we have learned from our experience. So I'm going to skip this because, but I just want to share that our borders are Thailand, Indonesia, Singapore, and Brunei, and then it's indicate that the supply of heroin is quite easy access to our country. Even though there are more drugs being abused, but opioid addiction, mainly heroin and morphine, remain our #1 problem. And then not just that, but the high-risk practice that make this program being accepted. It's not really because the government want to have the addicts, really, but they want to reduce the HIV and the complication of HIV. Because of that, there's a combine this program under harm reduction program. The HIV plus the cause that make the HIV increase in their prevalence, which is drug abuse due to the injection done by the addicts. So these all the figures that make them really worry before they know what to do with the drugs user, the drug abuse. Again, because the HIV and AIDS cases. What happens if you got caught with heroin or morphine? Of course, if you get caught more than certain amount, you will get into the prison, and you know what the corporal punishment into that, you know, that you're going to get hanged. But if you was found to be abused or dependent to that, according to the Act in 1983, you are given a privilege to be sent to the detention center, which called as rehabilitation center, drug rehabilitation center, which means that you have to stay there for 2 years. This is the detention, the custodial way of try to treat this individual who abuse drug. So you have to be in 2 years in the drug rehabilitation center. This center has been managed and monitored by National Anti-Drug Authority, or NADA, and is actually controlled by Ministry of Home Affairs. It's nothing to do with Ministry of Health in the beginning. And if the person who has been sent to this center, when they was released and they involved in drugs abuse again, they will send back for second time or third time, but eventually, if there is no improvement in terms of their habit, they will end up in prison. So, we need the paradigm shift to move from punishment to rehabilitation, to move from custodial to voluntary. And then we also have to move from social and moral model, which think that drug abuser is because of damage in their personality and their character, in their sinful things, to a biopsychosocial model, will believe that drug dependent is a disease or is an illness. And then we also move from complete abstinence of the drugs into harm reduction or substitution therapy. That is the idea, to help this addict by giving them something that less dangerous than the heroin or morphine itself. So methadone actually was first introduced in 1980s, maybe 1986, and it was used in the non-medical setting. Actually, it was used by NADA in the rehabilitation center as part of detoxification. And then they detox the addict, and then they release. After 2 years, they will be released. The problem, the relapse rate, very, very high. Almost all of them went back to their addiction. So in 2002, methadone was reintroduced 1 year after buprenorphine into our country. But the prescriptions were only done in the private GP and mainly in UMMC where Pro Hussain's work. The patient have to pay for the methadone and also for buprenorphine. So the price is not, compared to methadone, buprenorphine is a little bit much more expensive. So we have to convince the policymaker that these drugs, either methadone or buprenorphine, are really works. But they want the evidence. They say us, before we show you the money, show us whether it's going to work or not. Because of that, the first project, the pilot project, was done in UMMC, again, where the Professor Hussain is part of the team. The first pilot study was done in 2003. The main objective for that is to find out what is the best possible program that we can suit in our local setting. And then we also want to know what is the dose that required for Malaysian population. Are we different compared to Western, where the drug has been used quite widely? And then we also want to know what are the possible problems that may arise before we implementing such program, especially about diversion, about abuse. The medication will be abused. So this one, the aim, as mentioned earlier, and then the subject was recruited by advertising in the newspaper and also through the word of mouth. Then the aim initially for 100. This project actually is initiated by the UMMC on their budget. There is no grant for it. They use their own grant. So the financial is really a big limitation. Initially, the aim is 400, but because of financial constraint and the ethical reason, because they found the results are so good until they said it's unethical not to start the program. The inclusion criteria are age 18 and above. They need to confirm that they are heroin user by urine test. And then another requirement is there must be some supportive carer that will agree to give the guarantee that they're going to be with this person. The reason for that, in this study, the methadone will be taken away, not a direct observation. I will talk about direct observation therapy, DOT, a little bit later. In this one, the person can take away the methadone. And then they are really worried about the fact that the person will abuse it, so they need to have someone who is going to be the carer for this person. And then they also have to agree that they will buy the methadone at their own cost after the completion of the study. At this time, the methadone is not free. The exclusion criteria, the concurrent use of medication that interact with methadone, and severe liver function, liver impairment. So the protocol, the start 10 milligram methadone. At this time, the methadone in the tablet form, not in the liquid form. And then if start given in the morning, if the withdrawal is still present, the additional dose will be given, 5 milligram, after 1 to 2 hours, until there is no more withdrawal. And then during day 2 until 56, they will increase the dose to find the right dose for the patient to stop from withdrawal symptoms from appearing. And then the reduction phase. At this time, there are still believe that there is a possible to gradually reduce the dose of methadone if there is a need to do so. But this is not compulsory. And then monthly, there will be assessment on their relationship with their carers, work performance, and whether there is high-risk behavior or criminal activities. Urine was done randomly to detect whether they use any heroin at the same time or not. 40 clients were initiated with methadone. The retention rate was 75%. Most of the dropout occurred at the early stage, and all the urine was positive initially, but gradually less and less positive urine tests, and then they are almost cleared by 120 days. The dose was 10 to 45 milligram. This is quite lower compared to other center at that time. And later on, in our few other projects, and then turned out to be this is very low. 80% reported better relationship with their carers, 60% improved their work performance, and then 50% of previously who did not employ and able to find a job, and none involved in crime or high-risk behavior. Because the results are so promising, the Ministry of Home Affairs and Ministry of Health think there is something good about this. So there is a potential for a good intervention to bring back the addict to the right path. But it takes a few years before the real program can be initiated. 2003 and then 2005, when the second project, nationwide program, has been implemented. So the challenges that we found during this first project, we found that the doctors who prescribe it, they're not being trained, and there is no limit how many patients they can initiate. After this one, after the project, this has been kind of motivation for the GPs, for the doctors to start giving methadone, because by the pilot project showed that it's a safe thing, safe program to do. Then the problem afterward, from 2002, 2003, 2005, these are the issues that we found. There are lack of training, there are no standard operating procedure, no clinical practice guideline, how it to be done. And because of that, some issues of diversion. The authorities worry that there are some diversion may occur. And then there is no good communication between different agencies. After a few years, after two years, they come up with a new format that lead to the second project. This is the pilot national MMT program. It started in October 2005, involving 1,250 heroin dependent and 18 center. When center means the Ministry of Health clinic, the health clinic, who can offer this program. The addicts again need to be confirmed dependent, age 18 and above, voluntary with written consent, no acute mental or medical illness, again normal liver function, no allergic to methadone. So now they have the guideline, the manual, how to do it properly. Then they also have an assessment to assess the drug use and HIV risk behavior and crime rate. This OTI, Opioid Treatment Index. And for the general health and well-being, the modified SAF 36, the quality of life, WHO QOL, and urine for drugs. The assessment was done at baseline, 6 months, at 12 months. All the 18 centers will follow the same protocol. And then the methadones are free. The results, very promising. The retention rate, 1 year, 80%. And then this program able to reduce the drug use and HIV risk behavior, the higher employment rate, and reduce crime, similar to the first finding. But this one with a bigger number, bigger sample size. And then the issue now, as Prof. Hussein mentioned, that the government really excited about the program. So there is some good thing after many years of trying. But they want more. That's the problem. When you deliver, you have to deliver more. So now they said that we want 25,000 addict under this program by 2010. So we have to upscaling. So we have to more people who are able to give this program. And then the issue about high regulated model versus low regulated model. In the program, the patient, or we call it client, will come every day to the center and then take methadone under supervision by the pharmacy. So the pharmacists need to be in the center. So they call it DOT, Direct Observation Therapy. So that is how we do to avoid diversion, avoid from being abused. So this is called high regulated model. When low regulated model means that the methadone can be taken away. I mean, can be bring home and then they come back every maybe 3 days later or 1 week later. So there is the possibility of abuse of the sell the methadone is there if there is a low regulated model. However, we have to bear in mind our aim is for them to able to function. If they have to come back every day to the center for the treatment, how are they going to work? Meaning that they have to organize themselves again so that they're able to come and get the medication and then go to work. Because there is some hassle, because some of them live quite far away from where the centers are. So that is the issue, that is the dilemma, whether we want to do the high regulated model or low regulated model. And then there is no body that monitor how many of really, whether they move, they go from one center to another. Again, this ongoing issue, the lack communication between agency. Because we know that there are different ministry involved, Ministry of Health, Ministry of Home Affairs, the Anti-Drug Authority, and then the GP, the private GP, and then the doctors from a different center, the pharmacy. So there are a little bit communication, and then there is no case manager that manage everything. So there is a issue that we are facing at that time. So now we move to another way how we can increase the number of addicts that we can treat. So they think about why don't we go to the aftercare center. Aftercare center is the place where the drug addict who are being released from the rehabilitation center, they go back to their house, but they still have to report back to the National Anti-Drug Authority for every month for two years, as under the parole, considered as a parole system. So they use this aftercare center to be the place where the methadone program can be established. Again, was initiated by UMMC, Dr. Rushdie and Prof. Hussein, the main person who make this program as a success. They started in 3 centers, and then the result is for 1 center in Kuala Lumpur. So this is the first time all the multi-agency come into contact. The setting and staff provided by anti-drug agency, the psychiatrist from UMMC, methadone, laboratory and monitoring given by Ministry of Health. Again, I wouldn't go through all the procedure, about the same as the previous one. And for the one in Kuala Lumpur, 52 clients screened, 2 was excluded for 50, and all of them remain with the program for after 1 year. 2 are actually still under program, but they has been transferred to other center. So this is a better one because they are more involved in counseling was given, and then this is the part where it's more like a community rather than in the clinic or in the hospital. But the problem is somehow the people who are interested are very, very low. It's like they take a long time for them to agree to be part of the program. And then we also found that the high comorbidity of amphetamine abuse as well. And then the staff, because I mentioned most of the staff, the counseling staff from anti-drug agency, they are not properly trained. So there's something that we found difficulties. So then they've also the client also complained that because they are still having this mindset of custodial, because they are from anti-drug agency, they still believe that this is a part of don't 100% believe that this is a disease. So they still have that mentality of custodial punishment. Then the clients are not really happy. Again, explain the slow recruitment rate. And then, how can we increase the number of people that we can invite into this program? So they go into, why don't we go to the prison? Because more than 65% of people who are in prison have a drug problem. So that case, we can upscale the number of people that can get the methadone program. And then some more, we know that the HIV, hepatitis is a very major problem in prison. And then most of these people who are involved in drug in prison causing a lot of problem to the prison staff. Then they tend to come back to the prison. The recidivism is very high if the person involved in drugs. So these are the reason why the prison is another place that the methadone program was initiated. So these are the reason. In prison, the dose of methadone need to be lower because they are considered as a abstinence. They are forced abstinence, so the dose was 2.5 and then go up to 5 milligram. And then we also found that there are a lot of side effects for people who had methadone in prison. Again, the recruitment, The recruitment is okay, but we need to slowly increase the dose of methadone. For this study, the dose that we found that optimum for this client between 60 to 80 milligram, which is quite similar to what other centers abroad normally use. So there are expansion of the service after the first pilot project that we established in Pengkalan Cepa in April 2008. And now we have 31 prisons in Malaysia who have methadone program in their prison. The last one, the final project that I want to talk about is the one that initiated in the Drug Rehabilitation Center. Remember, I mentioned that once they get caught, they will send to Rehabilitation Center for 2 years. So this is the place where the methadone program was established. This one is based on voluntary for inpatient and outpatient. For inpatient, meaning that they will be detained for 6 months instead of 2 years. During 6 months, they will have this methadone program and will be released to the community back to their home. As outpatient, for those who are already in the community and then they're having this problem, that they come and register under this program. So this is the basis for cure and care clinic, which Dr. Umi, the last presenter, will talk about, because this is the basis for what we are doing right now. We want to bring back this methadone program to the community, not into the rehabilitation center, not into the hospital. That is where the way to go. That's what we think. So this table just the summary for all the 4 projects, because I minus the 5 projects. I just want to highlight the agency involved. So there are a lot of agencies involved for each of the projects. And then the collaboration between agencies are very, very important to ensure the success of the program. And then the psychosocial input also important. We have the counselor provided by the anti-drug agency, but some in the initial program they are not trained. So having difficulties to get the right reason, for the client to feel they are being the right kind of counseling. And again, I have to remind the mindset when they, in the beginning of the projects, are custodial and punishment, not rehabilitation. So, but after some times, we're able to have a better counselor after being trained. So, these are all the 5 projects. The first one, the one that managed to convince the authority that drugs addicts can be treated medically. National MMT, where the nationwide, from the one pilot study go to nationwide, which involve 18 centers, and then after care go to the community, but for the person who are under parole, and then prison is a totally custodial, and then try to treat them before they are being released to the community. And then the rehab center is the combination of aftercare and prison, combination of inpatient and outpatient, and this is the way that we are going forward to make the program in the community and as a voluntary basis. So hopefully we're able to do that. So this one, just to say that the experience that we have by go through this process of getting services established is not a linear one, not straightforward, but at the end of the day, it's a very worthwhile. But because looking at the result we have, that we're able to change the person from being a failure to someone who has something they can proud of, which reduce the number of high-risk behavior, which also maintain their relationship with their family members. So this is a success, but with a lot of hard work. With that, I thank you.
Dr. Zakaria, thanks for your presentation.